Hi, happy Thursday, and we're back at hashtag CArthritis for this year's Canadian Rheumatology Association annual scientific meeting in allied health professionals. So I'm here with Mark Harrison, and so we're going to talk a little bit about the data that goes behind some of these decisions. So you take the opportunity now to introduce yourself and why you're in the rheumatology space.
Okay, so I'm Mark Harrison. I'm an assistant professor at the University of British Columbia, Faculty of Pharmaceutical Sciences, also a scientist at the Centre for Health Evaluation and Outcome Sciences in Vancouver, and I'm an affiliate scientist of Arthritis Research Canada in Richmond. So I've been working in arthritis now for longer than I want to admit, really. I think it's what we're on 2019, 17 years. So I started out as an epidemiologist in Manchester, UK, and the first job I had was in rheumatology. We were looking at how well staffed the UK was for dealing with the care of patients with rheumatology conditions. I also moved on to doing epidemiology, so looking at the stats behind biologics as they came onto the market. So we held the biologics register at the unit that I was working at in Manchester.
Wow.
And so we were looking at the safety of drugs, and I think from that sort of early start, those few projects, it got me hooked on rheumatology. And I then did a PhD. We sort of collaborated with a different university in the UK who were looking at the cost effectiveness and value of these drugs.
Right.
And I did a PhD, which then took me into the health economics space. So kind of taking those epidemiological skills and sort of building in the health economics lens, because I'd done business as an undergrad.
So we're lucky to have you, I guess.
I hope
we
so,
got
yeah.
lucky early on, and you never left.
Yeah, and I came to Vancouver in 2014, so I'm coming up for 5 years in Canada now.
Excellent.
So, yeah.
So you started out in the UK, and I mean, there's clear differences between Europe and Canada. So maybe speak to a little bit of the influence you had early on in how you used your craft to help change things in Europe, and then I guess speak a little bit about what's coming for Canada.
So I've kind of moved around a little bit in the UK and taken advantage of big data sets. So as I say, some of the work I was most proud of in Manchester was looking at big data, this national data set we had on biologics to try and work out safety of drugs. So we found some interesting findings there which kind of worked their way into practice. And then I shifted through my health economics role, into looking at quality of primary care through intensive schemes in the UK. And that's kind of led me into an interest in the patient-physician interaction, like how we can try and improve that for the good of healthcare and the patient's health, and how we can better understand decisions that are going on in that space. So that kind of takes me into two main areas. So one is using big data sets to try and see whether the changes that we make in the healthcare system actually translate into patient benefit.
Right.
And then also more survey-based on qualitative work, which is actually talking to people and trying to find out what drives people's preferences and decision-making process, and trying to understand how that can sort of inform us about the decision-making process and what can be changed there.
So there's big power behind these numbers. In order to be able to logically predict someone taking a medicine, I mean, I wouldn't even think how you would even gather that from data.
Yeah, well, to do that, we've borrowed techniques that are kind of marketing techniques. So you can imagine if Apple launched their iPhone, they don't just throw that product out onto the market. They go to people who may look like the consumers that they're trying to target and say, what features do you like? This is a prototype, does it work for you? And then some of the things they do is try and understand, when they're pricing that product, how much each of those factors, so you can imagine there's factors in the phone like the colour, the memory life, the quality of the camera, all these things. So you can design surveys which ask people to make repeated choices, and you vary features between these choices. And by sort of seeing how people respond, like which side they choose, which product they choose, you can get a value on the different features of a treatment, of a phone. So we've kind of translated to that. So what are the key features of a treatment decision. Is it safety, is it effectiveness, is it how the drug's taken or something like that. And we use the same method, get people to make choices, and that should reveal what's most important to them in that decision-making process. And then we can use that to try and say, well, given that treatment, whatever treatment we're looking at, has these particular properties, does it look likely that someone will be willing to take that treatment in this situation? So that's kind of one of the methods we've been using, but as I say, that's been borrowed from the marketing technique and used to look at treatments.
So that's some of the work that you're currently doing with arthritis consumer experts and Cheryl Cohen and group. So I know you're in great hands there, and specifically have the patient in mind. So how is understanding the patient really helped you in what you do?
Well, these techniques that I've just described to you, we can't do those without speaking with patients and understanding what's important to patients. So if I try and guess what's important to people making those decisions, and I get the features all wrong, then we're not going to find any important information. So I think one of the parts of that sort of technique that I really like is that you have to start by talking to people and finding out what's important to people who might actually be in that situation. So Cheryl and arthritis consumer experts helped us to connect with both patients and relatives of patients who, in this decision we were looking at, it was preventative treatment for rheumatoid arthritis. So trying to understand people before they get the disease, would they be willing to take a treatment to stop the onset of disease potentially? So she and the group sort of connected us with all these people. We had some great conversations, understood what perhaps the 5-6 main things that people were interested in might look like, and then we built the survey from there. So it kind of starts with the patient.
Right.
We use that information to build a survey, and then it goes back out to a bigger group of people, and we try and represent their preferences and influences on decision there.
Yeah, it's as a patient, it's great to hear you say that patients are included right from the start. I mean, we're seeing it in research, we're seeing it in advocacy, and now we're seeing it here. So appreciate what you do. Do we have any questions yet? I think it's pretty early in Vancouver, but I mean, we're national, so.
How does health economics and patient-centered, can those two go together?
Yeah, that's a great question, because one of the projects that's built on the work that we did with arthritis consumer experts, we've kind of now moved into the scleroderma space because there's an interesting treatment to look at there. And that work's been funded by BC Support Unit. They're really interested in making research patient-oriented, and I think health economics is one of those areas that's, I think it's perfect, partly for that process that I've just described to you. Like we can't start by assuming that we know what's important to people, so it kind of forces you to go to people who are affected by decisions and talk to them and understand what's going on. And I think one of this project we're looking at is actually trying to work out whether health economics can be more formally integrated into patient-oriented research. So can it be used as a way of determining feasibility of studies? So if someone's going to look at a drug, we can use health economics at that early stage through that process of talking to patients, surveying patients, predicting whether someone would use a treatment. And that could give you an indication of whether something would be worth studying. So is it worth going to the expense and the time and putting people in the position of studying a drug? Is it actually going to be used in turn? So I think it's really central. I think health economics, even though sometimes I think it gets this criticism that we're just looking at the money and we're making decisions about whether treatments can be given to people based on the cost effectiveness, but I think it's got a really central role in starting the process, working out what people want and what people value, and then trying to make sure that that's embedded in the research process. So I think it's perfectly coherent with that.
So last night we heard from Andre Picard, who was talking about national pharmacare a little bit. So what are your thoughts on that? Because we have to be realistic in the sense that there's not unlimited money.
Mm-hmm.
So it has to be part of the conversation. So what are your thoughts on national pharmacare in Canada?
always feel like I'm a little bit biased coming from the UK, where I think
But it's those experiences that, I mean, they're valuable, right?
Yeah,
So,
and I think coming to Canada, like I always knew that healthcare was something we're very proud of in the UK, and it was never a stress about whether if you go and see a physician, what the implication is going to be financially or anything like that. And I think I appreciate that, but I don't think I really appreciated it until I came to Canada. And we, as the keynote was saying last night, we still have a universal system here, but it is much less universal than the UK system. So I was a little bit, even though I've worked in healthcare, I was a little bit bewildered when I came to Canada, of trying to work out how the different parts fitted together, what the financial implications were if I went to see the doctor. So I think I'm definitely someone who supports the move to more universal healthcare. But as it said, it comes at a cost. We have to be mindful about, can we afford all these different things? Can we be more frugal with the money that we've got?
Right.
And it starts with that value proposition. Like, is the healthcare that we're providing, does that represent good money?
right.
Or are we contributing to this 30% or whatever that's
Yeah,
wasted
so
in the
he
healthcare
mentioned 30% yesterday, that there's probably 30% waste in the system right now, and it's not really around treatments and stuff, it's more around the admin and the function and the workflow.
Yeah.
Would you agree with that number? I mean, that number makes a bit of sense to me.
It's scary, yeah, and it's a number that keeps coming up. So one of the models that was really interesting to me when I first came to Canada, because I took this healthcare sustainability position at UBC. So one of the first things I tried to do was like frame what sustainability means to me, and there was quite an influential model from the US which looked at this waste in healthcare and basically said you could get back to a more sustainable healthcare position not by spending more but by stripping out all this waste. And I do believe in waste in the healthcare system. There's a lot of redundancies that we do, there's a lot of unnecessary treatment, quite a lot of perverse incentives that make healthcare not flow in the way that would be best for patients and for the healthcare system. So I think that is important. And I think perhaps going back to people's preferences, like there's treatments that we give to people that perhaps for one reason or another they can't or won't take, and that contributes to waste as well. So that's one small area that I think we can contribute to.
Yeah, I mean, coming into this with a financial background, I started realizing the waste is out there just by the different things that you would hear. I mean, we have, I've heard that there's people out there filling their prescriptions so they can get points at stores and stuff, and I take a decent amount of medication, but I seem to know my body pretty well, so if I'm taking something that's not really having a desired effect, I'll stop it on my own through talking with my doctor and everything. But I mean, I don't needlessly take medication, right? I try to take as little medication as I can, but it needs to provide value for me. So, you know, it is true that there's likely a lot of waste out there of people taking things that maybe not having much of an effect. So, I mean, how do we even start to identify those drugs, and at what level or at what organization are they excluded and or sent through?
Yeah, I think one of that's a big question, and I don't think there's a single source of waste, and I don't think there's a single sort of big ticket item that you can say that this needs to go. But I think it's like one of the roles I do in British Columbia is on the Health Technology Assessment Committee, and we try and assess value at that stage as things come onto the formula or be available to go into the formula of being funded through the healthcare system. But I think one of the things we don't do enough of is looking at what we already provide and whether we should take things out as new things come on board, or whether we should replace certain treatments with others because they're giving more value for money. It seems to be when it's on, and we don't really sort of have the other side of the conversation about taking away. Other things are, one of the projects I'm really interested in at the moment is multidisciplinary care.
Right.
And I think anecdotally, again, and this isn't anything we've backed up by research yet, but we've talked to people, and nurses working with rheumatologists in BC have different conversations than rheumatologists do with patients, and that might help
Yep.
sort of better decisions about what treatments people could go on, like which treatments are A, good for them, B, match their lifestyle, so how you take that drug might be important, whether people can afford it, whether people can access that drug or treatment. And I think moving towards sort of more holistic, sort of multidisciplinary care could be a way of sort of finding out at the individual level where waste is coming at that stage. And I think waste is quite a negative word, but I think I always look at it as a positive from that sort of
Well, it's an
frame of the
opportunity,
question.
right?
An opportunity,
yeah,
exactly.
normally. Well,
Yeah.
I want to thank you so much for joining. Do we have anything else, Anita? What I can do is leave you with the question around, so this year's theme is building bridges. So in what you do, what does that mean to you?
So I think building bridges in my work is kind of like the recognition that I don't know what's important to patients. I don't know the process of what goes into ministry decisions, what goes into clinical decisions. But I think if I can bridge those by like talking to all these different experts who you've got around me, then I can bring what I'm good at, which is kind of the analysis or the study design, and we can try and answer questions that are relevant to all these different groups. So I think it is a kind of bridging process, recognising that I have a set of skills, but not all this expert knowledge that surrounds me, and sort of using those bridges to do better work.
And we face this with advocacy all the time. I mean, the best way to do business is ask your consumers what they want.
Exactly.
And the funny thing is, they'll tell you, right? So, been a pleasure. Fantastic meeting you, and I wish you the best of luck with everything.
Yeah, thanks very much.